chemical factors that affect wound healing. So these are external or drug-related agents that influence healing, either by interfering with cell function or altering the wound environment. Number 1, medications. For example, corticosteroids, e.g. prednisone and dexamethasone. These drugs are widely used in medicine as anti-inflammatory and immunosuppressive drugs. So corticosteroids are potent anti-inflammatory drugs which block phospholipase A2, leading to decreased prostaglandins and leukotrienes production. So in a normal process, upon injury, phospholipase A2 releases arachidonic acid from cell membrane, and arachidonic acid is converted into prostaglandins and leukotrienes. So these molecules promote vasodilation, vascular permeability, pain, and recruitment of immune cells, chiefly of neutrophils and macrophages. Corticosteroids induce lycopotine-1, which inhibits phospholipase A2. This leads to reduced production of arachidonic acid, hence reduced production of prostaglandins and leukotrienes. Secondly, corticosteroids suppresses immune cell migration, chiefly of neutrophils and macrophages. So in a normal process, neutrophils arrive first to clear bacteria or debris, and macrophages follow later, secreting growth factors like vesicular endothelial growth factor, transforming growth factor beta, and platelet-derived growth factor. These stimulate fibroblast angiogenesis and tissue repair. Corticosteroids reduce expression of adhesion molecules on endothelial cells, which affects the attachment and migration of neutrophils and macrophages into tissues. Number 2, corticosteroids impair chemotaxis, movement towards the wound. Number 3, induce apoptosis, which is cell death of lymphocytes. This leads to delayed clearance of dead cells or microbes, and fewer macrophages affects the production of adequate growth factor, hence slower fibroblast activation and angiogenesis. Number 3, corticosteroids inhibit fibroblast proliferation and collagen synthesis. Fibroblasts proliferate during the proliferative phase, leading to deposition of collagen type 3 and later type 1. So corticosteroids inhibit fibroblast division and reduce production of collagen, glycosaminoglycans, and fibronectin, which are all essential for extracellular matrix. They also reduce, suppress, or decrease the activity of transforming growth factor beta, a key signal for fibroblast activity. So this leads to weak extracellular matrix formation, poor tensile strength of the scar tissue, and increased risk of wound dehiscence or reopening of the wound. Additionally, corticosteroids reduce angiogenesis. In a normal situation, new capillaries are formed from existing vessels under the influence of vesicular endothelial growth factor, which leads to delivery of oxygen and nutrients to the healing wound. However, corticosteroid suppresses macrophage activity, which leads to decreased release of vesicular endothelial growth factor and also directly inhibits endothelial cell proliferation and migration. This leads to poor granulation tissue formation, hypoxic wound environment whereby fibroblasts and keratinocytes function poorly, and also slower re-epithelialization and wound closure.